third session we'll be introducing here is patient-driving research to improve outcomes. And we have two very interesting speakers here. Our first speaker is going to talk about quality of life in EHE, and it is our speaker is Catarina Simoes, who is a PhD candidate at the Netherlands Cancer Institute.
Hi, everybody. First of all, thank you for having me. Thanks, Denise, for the invitation. My name is Catarina Padilla. I'm a third-year PhD student at the Netherlands Cancer Institute in Amsterdam. So I'm based right now in Amsterdam, the sun is setting. And today I'm going to give a small talk about my main PhD project regarding health-related quality of life measurement strategy for solid rare cancers. And then I'm going to dive in a little bit into the EHE perspective. And of course, I am talking not only for myself, but for my PhD team, Professor Dr. Vinette van der Graaf, Dr. Margot Teselaar, and Dr. Olga Gousson. I don't have any disclosures. So rare cancers are those, well, I think we all know, with less than 6 in 100,000 people per year as an incidence. And although this may sound like a small amount of patients per year, in the European Union, we have approximately 24% of all cancers being a rare cancer. And recently, the ESMO has published that around 650 new cases of rare cancers are diagnosed yearly. And in the US, actually, 21% of all cancers are actually rare cancers, and approximately 375,000 new cases appear yearly. Rare cancers as a sort of a domain is known for its heterogeneity, with more than 198 subtypes, and it can happen literally everywhere in the body. So in 2017, the European Reference Network for Rare Adult Solid Tumors, the ERACAN, was created with the aim to sort of divide and, well, make it a bit more straightforward for research and clinicians to tackle these cancers based on the location of the tumor. So the first domain is actually sarcoma, and EHE is one of the subtypes specified by the ERACAN. Patients with a rare cancer are known to have specific diagnostic and clinical outcomes. And many times they are faced with late diagnosis, a delay in early detection, and an absence of a typical or uniform presentation. And more than that, many times patients are faced with less opportunities, either in terms of treatment options, participation in clinical trials and in studies, or a limited access to centers of expertise, depending on their location. But more than that, these patients are known to have an impaired health-related quality of life with a higher psychological impact, more distress, more anxiety, leading to a higher burden in their physical, their mental, and their social life. And when I talk about health-related quality of life, that's the main topic of my PhD. I'm referring the impact of the disease and the treatment on the physical, the mental, and the social functioning domains. So when we are assessing health-related quality of life, we want to investigate physical aspects such as fatigue. So we ask patients if they feel, for example, more tired than before. But we are also interested in their participation in society. So we wonder how is their relationship with friends and partners, and if their work has been compromised. And also, of course, in the mental aspect, if they feel more anxious than before, if they feel mentally drained, if they're more irritable, or perhaps even depressed. And what happens is that in the solid rare cancer field, health-related quality of life is generally measured by means of a questionnaire. And for this project and for my talk, it's important to keep in mind an abbreviation is called the ERTC, that's the European Organization for Research and Treatment of Cancer. And they are responsible for developing many questionnaires for several types of cancer. And they have developed a generic questionnaire called the ERTC Quality of Life Core 30, which is a questionnaire that asks patients regarding if they feel tired, if they have trouble taking a short walk, if they feel depressed. So extremely general and generic questionnaire. And that is most of the times the way to assess health-related quality of life in patients with a solid rare cancer. But then, of course, sometimes if available, patients can also be presented with a tumor-specific or a domain-specific questionnaire. And a tumor-specific questionnaire basically means that is a questionnaire focused on the location of a tumor. So it could be the ERTC quality of life brain tumor, for example, if it would be the case of a brain tumor. And a domain-specific questionnaire means a questionnaire focused on a specific domain, such as fatigue, for example. But what happens is that in rare cancers, currently there is no questionnaire for rare cancers. And whenever these patients are included in a trial or in a study, we see that there is a big heterogeneity in the choice of the questionnaires to be used. And that is a little bit the rationale of how this project was created, where we actually aim to create a measurement strategy for health-related quality of life assessment for the research, but also clinical practice, focused on the content and the specific issues that patients might face in regards of their health-related quality of life, mainly because of the rarity of their disease. So to do that, we first wanted to identify the current the current instruments and strategies available for these patients by means of a literature review, but we are also interested in understanding the content validity of tumor-specific questionnaires. And when I talk about content validity, it's important to keep in mind that we want to actually understand if the existing questionnaires are applicable for these patients. And to do that, we are interviewing patients and healthcare professionals by means of an interview where we collect qualitative data and with a questionnaire, quantitative data collection. And of course, more specifically, we have interviewed 20 patients with an EHE diagnosis and 5 healthcare professionals that have contact with these patients, either as a surgeon, either as an oncologist, either as a nurse. And so far, we have conducted a literature review study that has been published in the beginning of this year. I'm happy to share this with anybody, should anybody be curious, where we examined exactly how health-related quality of life is currently measured in clinical research within the solid rare cancer population, and we identified available health-related quality of life instruments and tools. And I think the main message of our literature review is how heterogeneous the availability of the data actually is. So we see that based on those 10 different domains that the IRACAN has created back in 2017, we investigated per domain how much literature do we actually have about health-related quality of life. And the heterogeneity is gigantic. But then, of course, in regards to sarcomas, we see that we have 66 studies found in our research that investigate health-related quality of life. But out of these 66, actually only 2 studies investigated EHE, and none of those were qualitative studies. They were questionnaire studies. So it really, really shows how scarce the information is and how much research do we actually need. But more than that, we are, we have recruited interview data from patients and from healthcare professionals, where we ask them to share potential health-related quality of life issues. So we ask them questions such as, do you feel any limitations before or after the diagnosis and treatment? Should you have any? Did you feel any impact in your relationships with family or friends? Any differences with partner regarding intimacy as well? Any hobbies were affected? So we really wanted to see the patient as a whole. And we also asked them to review and rate specific ERTC questionnaires. And of course, in the context of EHE, we currently don't have a EHE specific questionnaire. So patients and healthcare professionals were asked to answer, complete, and rate the ERTC, the generic questionnaire, the C30. And when we were collecting data, that's how I met Denise, of course, and we saw, well, we have something very important in our hands. So we have decided to specifically write a manuscript on the EHE specific data, because the few literature that exists out there shows that Indeed, EHE patients suffer from a psychosocial impact and a functional impairment. They have higher levels of distress, more anxiety, more feelings of being alone, and therefore a lower quality of life. So we started analyzing this data, and I'm happy to say that we managed to include 31 participants in this qualitative data. So this would be the first data out there. We had an equal division between men and women. The median age was 50 years old. Time since diagnosis in our population was 64 months, so approximately 5 years. And 20 patients had metastasis at time of the interview, while 11 didn't. And in regards to the treatment, 45% of the patients interviewed were in a watchful waiting or an active surveillance approach, while others were in active treatment. And we recruited patients actually from different parts of the world, from the Netherlands, Belgium, the US, the UK, Australia, Brazil, Denmark, Egypt, Canada, Germany, and Spain. So it is indeed a global effort, I would say. And while analyzing the qualitative data, we based our results in what we call the biopsychosocial model. So that is basically splitting all the results within the physical, the mental, and the social health. And in those patients, we saw that main themes regarding the physical health were fatigue, pain, respiratory problems, treatment or surgery-related complaints, and functional limitations. But we also saw that sleep disturbances impacted not only their physical health, but also their mental health. In regards with their mental health, we saw that worries, uncertainty, skin anxiety, fear of disease progression or recurrence, anxiety as a whole, changes in emotions, and cognitive changes were also mentioned by patients. But then, of course, I think one thing that was very striking, at least for me, was patients talking about the lack of understanding from family, from friends, but also from doctors, the lack of support, and an urgency to live life. So a sort of a urgent feeling behind anything that they would do. In terms of their social health, the patients mention lack of information, lack of treatment options, feelings of isolation, financial impacts, and impacts in their relationships. And finally, in regards with their social health and their physical health, patients mentioned loss of independence, impacts in work, and limitation in their social activities. And I wanted to just bring a little bit of an illustration of what I mean by all of this. And I highlighted some of the quotes from these patients. For example, in regards with the sleep disturbances, a patient said that at night it gets very loud. That's when I let my wheel spin and then I think about it. So they would suffer a lot from insomnia. But of course, patients would have a functional limitation. They wouldn't be able to carry heavy objects or clean the house. When it comes to the mental health issues, we saw that uncertainty was one of the main reported issues by these patients. And one specifically mentioned that, well, I thought the cancer would disappear, be eradicated after the radiotherapy, but that's not the case. The cancer is still there, and they are now monitoring to ensure it isn't progressing. And that goes in line with the fear of disease progression and recurrence, where a patient, for example, said, I suppose the trajectory is just understanding because you never know. It's like a bomb ticking away. You never know. Is it going to switch to progressive? So that just shows a little bit the baseline where these patients are coming from. And then I do think alongside with that comes the social health part with the lack of information and lack of treatment options, where they mentioned that it was a very rare type of cancer. There was considerable uncertainty about the treatment that they would apply, and that following a treatment plan based on a very small number, because the condition is so rare, still very uncertain. And this patient indeed often wondered, what am I doing this for? But of course, all of that impacted their work. They would sometimes feel that their head was a bit cloudy. They would have what they called brain fog, which would affect their performance at work. And patients mentioned that they felt almost like a fraud because it really struck me. They said, but it's just like so bizarre. You were walking around telling people you've got this cancer, but you feel like they don't believe you because you look so well. You almost feel like a fraud. And that came in different ways from different patients in different stages with different treatments and approaches. And as I mentioned, the urgency to live, that was also reported by several patients where they said, I think now I look more at not putting things off, not waiting. Let's make the memories now, let's do things now. I guess I feel a bit more urgency to do everything. So indeed, we see that being diagnosed with EHE impacts patients in all of their areas of their life. So after seeing this little scope of patients with a rare cancer, for the big project that we have, we see that based on the literature review, there is a current heterogeneity and a lack of strategy when it comes to health-related quality of life in patients with a solid rare cancer. And the main aim of the project is to create a guidance document on how to best measure health-related quality of life in solid rare cancers, specific per the 20 subtypes that we have for the project. And of course, for the EHE community, we do see that there are issues that patients report that are not fully covered by the questionnaires, as we see in the interviews. And because we use a generic questionnaire, indeed, we see many missing topics. And although I didn't show the questionnaire data that we have, the questionnaire data didn't reveal any significant results in regards of the most important questions, but the 2 questions related to pain were the most mentioned by patients as one of the most important ones. So in summary, we see that patients with EHE do suffer from psychosocial challenges in their physical, social, and mental life, but further research is needed for this population. And I'm happy to say that there's a manuscript in the oven, as I like to say, that hopefully still by this first semester is going to be out, and I will be very happy to share with all of you. But of course, I would like to thank my supervisory team and reinforce that collaboration is key. These are all the bodies involved in the big project, and the ones in red are the ones that recruited patients for this manuscript that we're working on. So indeed, collaboration is key, especially when you're talking about rare cancers, rare diseases, and in this case, of course, EHE. If you have any questions, I'm happy to answer the Q&A, but also feel free to send me an email. Thank you very much.
Thank you very much. I'm going to read a comment from the audience. This presentation is hitting to my core. A lot of these comments to the questionnaire regarding quality of life are exactly how I feel.
Oh, that's great.
We'll leave time for the very popular Ask the Expert. We're going to not have a Q&A for this 3rd session, but do please, if you have the time, take a look at the Q&A section, and if anything pops up, it'd be great if you could answer questions directly. And with that,
perfect. Thank you so much.
Thank you so much. With that, I'm going to turn it over to Sania Choudhary from the EHE Foundation to present.
Hi, can you hear me?
Your audio is perfect and your slides look great.
Thank you. Hello, everyone. I'm Sania, a Research Junior Fellow at the EHE Foundation, and today I'll be presenting about the Global Patient Registry. The EHE Global Patient Registry is a global long-term database that can be used to describe people with EHE from around the world. The registry uses patient experiences to drive research on EHE. It can help identify candidates for clinical trials, and it can also help shape care guidelines to improve care for patients with EHE. The data the registry collects includes sociodemographics, medical and diagnostic information, information about treatment and disease progression, information about management of care, and the quality of participants' lives. Anyone diagnosed with EHE from anywhere in the world can join the registry. The information entered can be for someone who is either alive or deceased. Patients who are 18 or older can register themselves, and patients under 18 may be included by a legal representative. The data is encrypted, and there is no sharing of any identifiable data. We currently have data from 236 participants across 29 countries. The majority, around 55%, are from the US, 10% are from Canada, and 7% are from the UK and Australia each. However, participants from other countries across Europe, Asia, and Africa are included as well. In terms of age, we can see that we are pretty evenly distributed across the 30 to 60 plus age groups, with the highest category being the 50 to 59 group at 26% of participants. This aligns well with the published literature for the incidence of EHE. In terms of sex, The registry is more heavily female-dominated, with 71% of participants being female-identifying and 29% being male-identifying. This is in part because females usually participate in studies revolving around surveys more, but it does not, however, mean that females are more prone to EHE, as that's not something that we can conclude. In terms of race, the registry is heavily white-dominated at about 85% of participants. Once again, though, we cannot draw any conclusions about incidence of race or incidence of EHE by race, but it's something to keep in mind while examining the data. We've been able to learn about the prevalence of EHE by location in the body through the registry. It's important to note that some participants have had EHE in multiple locations. The most common site of EHE among registry participants is in the liver, at about 53%. The second most common site is in the lung, at about 36%. This also aligns well with the published literature, which usually shows bone as the third most common site, which we can also see here at about 11%. We have also been able to learn about symptoms that participants experience prior to diagnosis. 76% of participants reported experiencing symptoms prior to their EHE diagnosis. For the 24% that did not experience symptoms, we can assume that the EHE diagnosis was an incidental finding, meaning that the participant went to get seen for another medical concern, but the providers ended up finding EHE. Of the types of symptoms experienced, the most common across all participants was pain at the tumor site, at about 33%, and the second most common was fatigue, at about 26%. The third most common was abdominal pain at around 23%. These symptoms did, however, vary by EHE location. So for example, the most common symptom in participants with EHE only in the liver was abdominal pain at 35%, whereas the most common symptom in participants with EHE only in the lung was shortness of breath at 24%, followed closely by cough, chest pain, and upper back pain, all at about 19%. The most common symptom in participants with EHE only in the bone was pain at the tumor site, at about 50%. The longer we continue to develop the registry, the more that we'll be able to learn about how these symptoms develop and change over time. When it comes to misdiagnoses, we've learned that about 19% of participants were originally misdiagnosed. The chart on the right shows some of the misdiagnoses that participants initially received. The most common misdiagnosis is sarcomas at about 6%. Within sarcomas, the most common misdiagnosis is angiosarcoma. Closely behind, the second most common misdiagnosis is a major organ cancer at about 5%. These have included liver, lung, kidney, and breast cancers. Understanding the frequency and types of misdiagnoses that EHE patients receive can help inform clinical care to improve rates of correct EHE diagnosis, which can then improve care management and timely treatment for EHE participants. Using the registry, we are able to perform subgroup analyses, such as looking at EHE presentation in different organs. For example, we can look at characteristics of tumors at diagnosis in the three most common EHE sites: liver, lung, and bone. We've learned that a majority of tumors that were found in the liver were found only in the liver, at about 59%. We've learned that the most common number of tumors found in the liver were more than 5, and the most common size of the largest tumor found was between 1 to 5 centimeters. Contrary to the liver, the vast majority of tumors found in the lung at diagnosis were found in the lung as well as other locations, at about 72%. Like the liver, the most common number of tumors found were more than 5, at 64%. However, the most common size of the largest tumor was smaller than 1 centimeter. Similar to the lung, most of the tumors found in the bone at diagnosis were found in the bone as well as other locations, at about 58%. However, different from both the liver and the lung, the most common number of tumors found in the bone was only 1. Like the liver, the most common size of the largest tumor found was between 1 to 5 centimeters. Through the registry, we've also been able to learn about treatments among registry participants. The graph on the left shows that most participants have received a treatment at the time of joining the registry at about 61%, which in this case means that they have had some form of an intervention. The other 39% were under active surveillance at the time of joining the registry. The graph on the right shows that of participants who entered where they're being seen, either for treatment or for active surveillance, just over half of those participants have been seen in a large academic medical center, but 44% of them have not. This is concerning because the 2021 consensus paper states that people who are diagnosed with EHE should be seen by a multidisciplinary sarcoma team, which is most commonly found in large academic medical centers. These graphs will inevitably change as we receive more data over time from the semi-annual follow-up forms from participants. Here we can see what we've been able to learn about the utilization of different types of treatments among participants. Again, it's important to keep in mind that some patients have undergone multiple treatments. The most common treatment currently is surgery at 31%, and the second most common treatment is systemic therapy at around 22%. This is closely followed by pain management, supportive therapy, and immunosuppressants, all of which are around similar rates. We have more data behind what's shown in this figure, for example, what kinds of systemic therapies people are using or what kinds of resections they have undergone. And with more people contributing to the registry, we'll be able to do more analyses on these types of treatments, for example, the effectiveness of different systemic therapies. But currently, we don't have enough data to draw such conclusions. So how can you contribute to the EHE Global Patient Registry? If you are able and eligible, we strongly encourage you to join. The image on the right shows how you can join the registry. One way is to visit our website at fightehe.org, then click on the drop-down tab at the top center that says Research, then click Patient Registry. You can read more about the details of the registry on that page, and when you're ready, you can click the red button saying Join the Registry to get started. You can also navigate directly to fightehe.org/registry. We encourage you to use your story to advance research on EHE, and if you have any questions, please feel free to email registry@fightehe.org, and we'll be happy to help. Most importantly, we would like to share our deep gratitude for all participants who have joined the registry. Thank you for all the time and effort that you have devoted to making the registry what it is today. We would like to thank the National Organization for Rare Disorders for allowing us to maintain our registry on their platform. We would also like to thank Jane Gudkovich, Smriti Rai, and North Star IRB for their help in developing the registry. Finally, we would like to thank the generous donations from the community and a grant from the Rare as One Chan Zuckerberg Initiative, which allowed us to create the registry. Thank you, and I'm happy to take any questions.
Excellent. Thank you so much.